Started.
My mom taught me to sell at a spaza shop. She ran a hair salon. I pretty much learned entrepreneurship from my mom's.
Umntu ngumntu ngabantu. That on your own, you can't really do it. You need the support of those around you.
You will have a network of people, a network of communities, and a society that will make sure that you count.
It is Thursday evening and you are tuned in to SAITA Media Facebook page for the program SAITA Straight Talk. Now, the Straight Talk series is powered by SAITA, and SAITA is the acronym for the South African Informal Traders Alliance. And in this program, we discuss issues that are pertinent to the sector. Sometimes it's humbling issues, sometimes it's burning issues. And tonight, we're going to be talking health issues. My guest this evening is Dr. Khosi. Good evening, Doc, and welcome to SAITA Straight Talk.
Good evening to you and good evening to the viewers.
Doc, tell us a little bit about yourself, please.
Basically, I'm trained as an ophthalmologist. So that's what I do for a living. I fix people's eyes. And in my spare time, I'm a health activist. That's basically how I describe myself. I was born in Soweto, and I went to various schools, including in Old Transvaal, Northern Province, Free State, started university at Fort Hare, ended up at a medical school in Devon, qualified in 81 as a doctor, qualified in 88 as an ophthalmologist, and I've been in private practice ever since. I've been involved in medical politics. I chaired the South African Medical Association for 9 years. I was president of the World Medical Association. I then went into health regulation. I was in the HPCSA for 10 years, and I was its president till October last year. And I'm currently still the chair of the International Associations of Medical Regulatory Authorities and the president of the Council of Medical Associations in Africa. So I've been active in medical circles, for lack of a better word, medical politics. And around 2006, as the president of the World Medical Association, I became interested in harm reduction. Or I was engaged in harm reduction because in 2001, when I became chair, I got engaged on HIV/AIDS issues, and the Medical Association, in partnership with the Nelson Mandela Foundation, we put the first ARVs in the public sector. And the program was launched at GF Jooste Hospital in Cape Town, that some of you might be familiar with. That's the first place where South Africans got free antiretrovirals from the public sector. I was part of that program. So that's where harm reduction began for me, and it became intensified when I was president of the World Medical Association. I've been involved with International Association of Patient Organizations. I've consulted in the food industry, alcohol industry, and I'm now engaged with tobacco harm reduction.
So the term harm reduction is quite a broad one. And just for the sake of myself and our viewers, I went to Professor Google and I asked, what is harm reduction? So Google gives quite a beautiful definition, and it says harm reduction or harm minimization refers to a range of public health policies designed to lessen the negative social and or physical consequences associated with various human behaviors, both legal and illegal. So that makes the scope very, very wide. Right now, we're sitting in the middle of a pandemic. So, I mean, all of the harm reductions at the moment has been quite product specific. But I want to go to the softer issue, just as a start, Doctor, because with the pandemic, I have never, or I haven't in my life heard so many people feeling blue, people feeling anxious and all of that. So let's start with harm reduction in terms of just the psychological side of the being.
Well, as you say, harm reduction is quite common and it's embedded in everyday practices. Use of safety belts in cars. That's to reduce harm associated with vehicular accidents.
Yeah.
Airbags in cars. It's to reduce harm. Sophisticated braking system like anti-lock braking system that are to make sure that your brakes don't lock when you brake in wet weather. That's to reduce harm. Having tires that are not flat, that have threads, it's to reduce harm so that your car can brake. Washing your hands, that's to reduce harm. The other things I've been involved in, Global Hygiene Council, and I was the first person to popularize promotion of washing of hands with Dettol around 2006, 2007. That's harm reduction. So harm reduction is embedded in all the things that we do. When you have an auntie that puts 7 teaspoons of sugar in a cup of coffee, when you advise them, put 1 or 2, it's to reduce harm. When we say don't put salt in your food or too much salt, that's to reduce harm. When we change from drinking classic Coke to Diet Coke or zero sugar Coke, that's to reduce harm. When people change from alcohol-free Heineken, from proper Heineken to alcohol-free Heineken, is to reduce harm. When you decide to go to a place of pleasure and to limit the number of drinks that you're going to have, you are reducing harm to yourself. So harm reduction is fairly within our lives. When we talk about safe sexual practices, use of condoms, you are reducing harm. Reducing your sexual partners, you are reducing harm associated with sexually transmitted diseases. So it's basically quite a lot of things. When you are addicted to heroin and we give you methadone, or you are addicted to nyaupe and we give you methadone, it's a reduction of harm because that substitute that we give you is less harmful than what you are taking, and hopefully can be weaned off that substance that you are addicted to. So harm reduction, if talking about the pandemic, hand washing is to reduce harm. Yeah. Because a simple thing like hand washing reduces hospital-acquired infections, reduces the incidence of hospitals, reduces deaths, unnecessary deaths, and reduces costs to the healthcare system. Simple act of hand washing. Wearing of masks during a pandemic like we have, it's to reduce harm to yourself and to others.
You said something very interesting now that I just want to latch onto, and that is to take the pressure off our healthcare system. I mean, in South Africa, we have got the majority of our people that are dependent on a public health system, which we know is under pressure without a pandemic. So just, you also mentioned about your last product that you mentioned in your introduction was about cigarettes. Now, I live in the Western Cape, and in my community, smoking is almost a rite of passage, if I can be that blatant about it. People smoke all the time. We hear and we see that people say that how harmful smoking is for you, how much your body changes when you stop. There's even warning messages on cigarettes. So how do I reduce my harm if I'm a smoker? Because there are social smokers and then there are addicted smokers.
I think the first, a social smoker is one possibly on their way to addiction. Most smokers don't start by being addicted smokers. They start as social smokers. So a social smoker, that's the passage to being addicted. Now, some of the things that you'll observe in society, I mean, I also come from a time when smoking was quite high, but you'll see in communities where smoking is prevalent. If you look at your senior citizens, people that are in their 60s or above 60, a lot of them will have chest problems. They'll have chronic coughs. They will not have strong physical endurance. Because remember, the effects of smoking take time. Smoking kills 1 in 2 of its users.
Wow.
But the time when you get the diseases, it's if you've been smoking for 10, 20 years. And it's also related to how much you smoke. So the period becomes important. So the good news about that is that anytime you stop, we see health benefits. Even from people that have been smoking for 20 years, that have chronic obstructive airways disease, when they stop smoking, there's an improvement in their health. So, and also remember, there are other things that we don't talk about. We used to talk about secondhand smoke.
Yes.
Combustible cigarettes affect not just the smoker, they affect those around the smoker as well. Now, there are other things that happen that we sometimes don't talk about. When you have a smoker in your household smells. And it's an uncomfortable feeling. It's not a healthy environment to be in. When we used to fly and there was smoking even in aeroplanes, we used to have a smoking and a non-smoking section. And guess what? All the smokers would buy up the non-smoking seats. And they would sit in the non-smoking section. And you don't smoke, but you couldn't find a seat. So you're sitting in the smoking section. And you see them walk from the non-smoking section to come to you, smoke, and give you their second-hand smoke, and go back to the cleaner environment in the non-smoking session. So even smokers know of the ill effects of smoking. So when we talk about the harms of cigarettes, we mustn't forget the harms of secondary smoke, that others are also inhaling. They don't have the pleasure of looking cool with it, but they get the diseases that are associated. The children that are exposed to parents that smoke in close environments are in trouble. My father used to smoke a pipe, and he'd light up inside the car.
My father too.
We're not living in a democracy. So, just understand the issues about smoking. But here's the key issue about smoking and the harms of smoking. The biggest harm is produced by combusting the cigarette. When you light up the tobacco, you produce over 7,000 chemicals, some of which have been found to be carcinogenic by both the World Health Organization and the FDA.
So how is it legal? So how is it possible that I can buy something, over the counter, pay money for it, but when I light it, it has this effect?
It's legal because of the economic pressures. It's legal because it's part of the economy. I mean, your members will know that cigarettes are dangerous, but they're not going to stop selling them because they earn a living by selling them. So it's part of commerce. If you look at the things that we're up to right now in COVID, we are now doing the management of the economy rather than the management of the disease.
Yeah,
and our actions are informed by wanting the economy to be reignited.
Yeah.
So smoking is going to stay legal because it's part of the economy. But here's the beauty about keeping things legal. It's that you can regulate them.
Okay.
You can you can set product standards. So it's actually safer when things are legal and they can be regulated. Because when you ban something or you make it illegal, you drive it underground. When it is underground, it's now a police matter. So you can be involved in product standards, making sure that they are as less harmful as they could be, that poisons don't go in there, that there's proper manufacturing standards. You know, most of us die from food related diseases, but we're not going to make food illegal. And it's part of commerce. And food has become more harmful because of industrialization. You know, when you have to produce food in industrial quantities so that you are a listed company, you put preservatives, you put things that make the food harmful. It becomes processed food and it's no longer, but nobody is going to make it illegal. All we can hope for is to come up with the standards, like the Department of Health has come up with standards to reduce the amount of salt in certain things, to come up with a sugar tax, reduce sugar. When the drink has high sugar, it's taxed. When it's got low sugar, it's a lower tax. When it's got no sugar, there's no tax. So you got a tax regime proportionate to the degree of harm that is caused by the product. But you can do all that because it's illegal merchandise. So understand that it's better for all of us that the cigarettes stay legal. I mean, you've seen when there was an alcohol ban during COVID, a few families died from home brews in the Eastern Cape. That's because now you are not producing things that are vetted, that are safe.
Yeah.
There might be issues about intoxication, but now you get deaths directly from the product itself because it creates poisoning. Because it's not regulated and it's not being produced safely.
Yeah.
So it is important that things not be banned so that they can be controlled. You can also measure the amount that is being consumed by society, and you are able to study it. For us in the medical field, and for those of us that are scientists, if it's illegal, you can't research it. If it's legal, you can do research on it. You can find out what are the things that makes it harmful. You can get to a point of saying, how can we make it less harmful to society? What is it that people want from this foodstuff or from this cigarette? Can what they want be given to them safely to avoid the thousands of chemicals that are harmful? So the key issue about tobacco is that the most effective way of getting the nicotine is through combustion, but it's also the most harmful way of getting your nicotine. So the key issue is combustion. So when you move to non-combustible nicotine, it's less harmful than combustible nicotine.
So does that mean I have to buy those awfully tasting bubble gums that has nicotine in them to get the nicotine fix? Or are there other alternatives?
Well, what has happened is, if you go back into the history of tobacco control, in 1962, the Royal College of Physicians came up with a report that showed the link between tobacco and certain diseases, in particular cancer. And in 1964, the Surgeon General in the US also produced a similar report. So the efforts to control tobacco harm were born out of that. Fast track to that, in the 70s, there's a physician, a doctor called Michael Russell, who lived in South Africa for some time, but eventually was based in England, came up with the fact that smokers smoke for the nicotine, but they die from the tar, which is a product of combustion. So because of that, in the medical world, what we then came up with is what we call nicotine replacement therapy. How can we replace the nicotine for the people that are addicted to the nicotine and are getting it through combustion of cigarettes, which is very harmful? So the concept of nicotine replacement therapy came up. Now, what you're talking about, the gums, the lozenges, the sprays, sometimes even tablets, it's to replace nicotine. Now, when you look at it from the time of around the 70s, 80s, you either combusted the cigarette or you had smokeless cigarette in terms of snus, in terms of snuff in our environment. But snuff had its own issues, hygiene issues, they spit it anywhere. There are issues around that aspect. And then you'd have oral cancers from the irritation of that. But that was the alternative, was either you combust it or you ingest it orally or you sniff it.
Yes. Yes.
And that's how it was available. So in Sweden, they have been using a product called snus, which is basically the equivalent of our snuff, for more than 200 years.
Okay.
When it became evident that combustion is the problem, the major cigarette producer in Sweden sold their cigarette business to concentrate on the smokeless business, where they're selling tobacco that is not for combustion. That's how the miracle of snus was started 40 years ago. So all they did is to take the moist tobacco and they put it in a sachet, like a tea bag. So you have a small sachet that you put between your lip, upper lip, and your gum, and it sits there for about an hour, and that's how you get your nicotine. That has been proven to be far less harmful than combustible cigarettes.
I was going to ask you now. So how did that over time? Because obviously now this is legal, so you are able to research it. How did that impact the healthcare figures? Did you see a reduction in people's illnesses and how they died?
Well, here's the sad thing. As the battle with tobacco evolves, you'll then hear us quote as medical doctors that tobacco causes the greatest preventable harm to society.
Say that again.
Tobacco, it causes the greatest preventable harm to society.
Okay.
As I said, tobacco will kill one out of two of its users in their lifetime. Now, we have 8 million deaths per annum directly attributed to tobacco use. 8 million. With COVID, in 20 months, we're only getting to 5 million in 20 months. So it's almost that COVID kills more than double the number of people dying. Cigarettes kill more than double the number of people dying of COVID per annum. More than double. But you don't hear any, emergency action being taken to sort that out.
But
that's how grave the numbers are. But here's what happens, Louise. As I tell you about the short history of tobacco consumption and tobacco control, so in the 70s, there's activism against the tobacco industry. Marlboro Man, they've lied, they've hidden the fact that it kills. The sports advertising, James Bond, what's the thing that you remember about the first Bond movies? It's gambling, drinking, and smoking. So smoking is glamorized. Then you get a framework convention of tobacco control being developed in the WHO. And it is launched in 2005, and you have signatories to it. Now remember, during this time of the 60s of saying, smoking kills, and coming to 2000, in terms of product availability, nothing has changed. It's still the combustible cigarette, which is cheap to make, or smokeless tobacco. Then the framework convention comes in, and you have what they call Empower, which is basically to reduce the abundant availability of tobacco, restrict it to young people, restrict its marketing, tax it so that it becomes expensive, and offer the users cessation services. Those are some of the mechanisms embedded in the Empower concept of the Framework Convention of Tobacco Control. South Africa is a signatory, and as a signatory, even before others signed up, when our minister came on in 94, she started working hard at tobacco control. So we started with some of these restrictions long before people signed up to the FCTC, but all those strategies were embedded in the FCTC. So it is about restrict its use in public places. Don't make smoking popular, take them out of the common public places, etc. That's what's embedded in the Framework Convention of Tobacco Control. Now, when this framework gets promulgated and most countries are asked to sign on to this, Sweden now has this established smokeless tobacco product that they use in conjunction with cigarettes in the Swedish environment. Now, the FCTC is not really prepared to making a distinction. And guess what the WHO recommends?
Tell me.
Gives an exemption to Sweden because Sweden objected, and they were the major producers and users of snus, and it banned snus everywhere else in Europe. Snus gets banned, except in Sweden, and the neighboring countries also took, removed the ban. And Norway, Denmark, Finland, some of the Scandinavian countries cottoned on to using snus.
Mm-hmm.
Snus is used almost exclusively for the first 20 years in Sweden, last 20 years in other Scandinavian countries. Guess what has happened in Sweden 40 years later of using snus? Sweden has one of the lowest incidents of use of tobacco.
Because it's legal.
Smokeless tobacco has displaced cigarette smoking. They have a prevalence of smoking of about 17% of the adult population. But only 5% is cigarettes. The other 12% is snus. And guess what? Amongst men in Europe, the Swedes have the lowest incidence of tobacco-related diseases. The lowest incidence of cancer. Why? Non-combustion. Snus. So it's now well documented that the greatest harm comes from combustion. There's absolutely no question about that. There's no question that when you get your nicotine without combusting, you are dramatically reducing the harmful effects of tobacco. That's why in medicine, we give people nicotine replacement therapy. Nicotine in itself, it's a stimulant, but it doesn't cause cancer. Otherwise, why would we develop therapies, medical therapies that cause cancer?
So, doctor, do we have such options available? I mean, if I just think of we're talking about the informal trading sector, and you admitted earlier that people will continue selling cigarettes. So, do we have these alternatives available in South Africa to have less combustible? Will it cost me the same, or is it going to cost me more to have a cigarette that I, from what you are saying, non-combustible?
The challenge that we have, Louise, is that this is a complex industry. And I gave an address to an interest group in 2013. And I said to them, when you come to tobacco, the challenges for harm reduction are as follows. The governments are addicted to the revenue, the taxes that they charge. The companies are addicted to the profits.
Yeah.
And the smokers are addicted to the nicotine. So I reassured them that nobody will be banning cigarettes anytime soon.
Yeah.
Because of those addictions.
Yeah.
So it's part of business. And the biggest component of the price of cigarettes in South Africa is tax. So it's revenue for government. Cigarettes are cheap to produce. And they are the most effective way of getting your nicotine.
Yeah.
Now, around 2002, 2003, a pharmacist in Hong Kong called Hon Ling, his father died from smoking. He was a heavy smoker. He reinvented the electronic cigarette. The electronic cigarette was first developed in the 60s. Remember, I told you about the Royal College Physician report in the 62, and FDA Surgeon General report in 64. So there was interest in looking at alternatives, and the electronic cigarette was developed in the US at the time, but it could never be commercialized. It was not successful. So the successful electronic cigarette was reinvented by a pharmacist from Hong Kong. So the modern father of the electronic cigarette. Because you see, the nicotine replacement therapies, even though they are being given in health systems that have greater access, in South Africa, you can do it yourself. Their success rate is not sustainable. You give nicotine replacement therapy, 6 months, you get more than 50% have stayed away from tobacco. In a year, it drops to 20%. In 2 years, it's less than 10%. So relapse is quite high. Smokers don't like it. So he was a pharmacist. So he was fully aware of nicotine replacement therapies, but they were not suitable for him. So he developed a nicotine delivery system that simulates smoking that he was comfortable with. That has now been documented to be at least 95% less harmful than combustible cigarettes. And that is based on science. You know, when you use an electronic cigarette or a non-combustible alternative, you dramatically reduce the chemicals that you are exposed to that cause harm. Some of them are like carbon monoxide, are completely eliminated because they are direct products of combustion. Others are reduced with magnitudes of 93%, 85%, 99%. So they are greatly reduced. And clinically, the smokers feel better when they move to the variety of non-combustible products. So it's only in 2002 that it was reinvented. And it only picks up around 2013, 2015. E-cigarettes become popular, they make a comeback in a big way, and they become an alternative, and smokers prefer that way. Then there are other non-combustible technologies that have come up, like heat not burn, which is your IQOS, where it avoids combustion. It heats the tobacco and it produces the aerosol that delivers the nicotine. With electronic cigarettes, it's nicotine, which is largely extracted from tobacco. Sometimes you get synthetic nicotine, but the overwhelming majority of nicotine is sourced from tobacco. So that liquid is then vaporized by an electronic device. That's why it's called vaping. So it's vaporized and it produces a vapor, and that's how you get your nicotine. There are other chemicals that are in there, colorants, flavorants, and propylene glycol to produce the artificial smoke. You know, the smoke that gets produced at concerts is the same chemical that is used in e-cigarettes to produce the what looks like the smoke. So, but it is nicotine, and it is being vaporized through an electronic device. With heat not burn, it's tobacco that is specially prepared, and there's a blade that heats it up with the IQOS, and the other, like glow, use different mechanism, but it's the same thing. You're heating up the tobacco. There's a product from Japan.
So it's not burning.
It's not burning. You don't combust. You don't get to produce a flame. That's the key issue. You don't combust it. You know, do you drink coffee?
Occasionally.
Occasionally. You know, coffee.
Occasionally.
Drink coffee. It's a stimulant. I'm one of those that drink coffee. And it's a stimulant. But it's less harmful to us, or much safer, because we drink it, oral consumption. Can you imagine what would be the impact if we were smoking our coffee? Lungs are very sensitive. Lungs are very sensitive. You'll be surprised at what people smoked during COVID when they couldn't get their hands on cigarettes. But anyway, we'll leave that for another day. So it's the combustion that's the problem. And it's non-combustion that is key. Now, coming to the question that you asked about, you know, the communities that you serve, lower LSMs, disposable income not being great. What I've told you is that there are alternatives that can be adopted, but by low to middle income countries. I'm told that one of the companies that produces snuff, Taxi, may have gone into trying to put the snuff into pouches, create snus, Taxi snus. Those are things that can be done. You can import snus. Now, we even have nicotine pouches. Is the latest product that has been developed. So instead of tobacco in a sachet, it's nicotine in a sachet. So you put that between your gum and lip, and that's how you get your nicotine. And that is as close to nicotine replacement products as we can go. But it delivers enough nicotine over a prolonged period, and those that use it are satisfied. I hear they were popular in Kenya, the nicotine pouches. So there's still other innovations that are going to come of how to get your nicotine reducing harm. But remember, what I should have said at the beginning is that less harmful is the key phrase. Less harmful is not the same as not harmful. So as a physician, the first advice I would give you is quit. Might not be good for the business of your members, but for the person that has a smoking habit, the best thing you can do for yourself is to quit. But there are 1.14 billion smokers in the world today who are unable to quit or don't want to quit. And we can't let them die because there are less harmful products that are available. And we have an ethical duty to make those available. Now, our duty in countries like South Africa, in low to middle income countries, is to ensure that they are available even to the poor so that you can be able to pay them. So we need to have a discussion in terms of what you can do. But like I've said, snus is affordable. It should be readily available. You don't need electricity to have your nicotine. But also, there could be engagement about what we do about the other products that are expensive. In England, e-cigarettes have made such a difference in their cessation clinics, where switching from smoking or quitting nicotine use altogether, there are higher rates of doing that with e-cigarettes, that the cessation clinics under their national health system are now offering e-cigarettes to addicted smokers. They've just done a pilot where they are offering e-cigarettes in their mental health institutions. Remember, smoking affects poorer people, lower LSMs, but it also affects vulnerable populations like people with mental illnesses, indigenous people, sex workers, LGBTQ. Those groups are more vulnerable and the smoking rates are higher amongst them. So it is important that as a health measure, we ensure that there is access to alternatives to combustible cigarettes that are also affordable. That would also strengthen your members, because if they are affordable, it means their customer base can switch. Price should not be the barrier to switching. And we need to work together to ensure that the reduced risk products have a favorable tax regime so that they become affordable. They need to be price competitive to cigarettes if we're going to encourage many of our smokers to switch to the less harmful products. And that's where your members have a role in ensuring that we speak to the health authorities, we speak to Parliament, we speak to the tobacco bill to ensure that there's differentiation. Not all smokes are the same.
Yeah. Those are very, very powerful words, Dr. Kgosi. Thank you so much for gracing us with your presence and your insights this evening. I think we've got it loud and clear from the doctor. You have one of two choices. The first one, which will make the doctor very happy, is to quit entirely. And the second is to find an alternative to any tobacco product that you need to light up. So if you are a trader and your bread and butter comes from selling cigarettes that need to be set alight, I'm going to ask you, contact us at SAITA and let us work together.
Before you go, Louise, I just need to share something with you.
Please.
I was appointed to be a commissioner. We were commissioned to produce a report, and 5 of us were involved. Myself from Africa, a colleague from Indonesia, a family practitioner from the UK, and an ambassador in the US, and an economist. So there were 5 of us, and we produced this report. That report is available as a free download. Fightagainstsmoking.org. You can get that report, because we want to reignite the fight against smoking.
Yeah.
Remember the key thing. The fight is against smoking, not against smokers.
Yes.
Smokers are human, and we need to give them alternatives and give them the support that they deserve. So what I hope your SAITA members will do is, when the bill that regulates tobacco comes up, they need to come up and they need to give inputs to that bill about the importance of differentiation, the importance of affordability of alternatives, so you are still able to give your customer base alternatives that are less harmful, that are still affordable. But more importantly, let's give people an education about tobacco. Remember, it is not the nicotine that is the problem. It's the products of combustion that are a major problem.
Yeah. Thank you. Thank you, Doctor. So if you are interested in finding out how you can assist your customers in reducing their harm by providing them with non-combustible cigarettes, please, the SAITA membership number is on the screen. Contact us. There's an email address also. Then we have your details, and when the bill comes up and we require to give input as SAITA, we can do that from our members. Again, Dr. Kgosi, thank you for availing yourself this evening and for this very, very insightful talk. From me, Louise, until next time, for SAITA Talks, for SAITA Straight Talk, it's good night.
Thank you, and good